I'm here to tell you that where medicine is concerned, we can do amazing things here in the Flathead Valley. But I didn't always think that way. You see, I grew up in the big city, and I trained at university hospitals. And there we had high tech, and we had evidence-based medicine, and we had professors crawling the hallways waiting to tell us the latest, greatest, best, and truest thing. However, big city medicine, university hospital medicine wasn't perfect. It was this little matter of hardly ever seeing your patients. And if you did see your patients, maybe that's it. You only saw them once. Continuity of care was pretty much non-existent. And, well, then there was the practice environment. You had overpaid or underpaid, overworked residents. And then everyone was always in some sort of competition. And it certainly wasn't cooperative. In fact, sometimes it was downright hostile. It was dog eat dog. So when I came here in 1994, 20 years ago, as a newly minted obstetrician gynecologist, I had more than a little bit of trepidation about practicing in a small town. Because back in the big city, when some doctor from Podunk or River City would send a patient to us, we pretty much made fun of their small town practice ways. So this is a picture of the newest Denver General Hospital. That's where I did residency. And this, of course, is River City right here. When I got here, indeed, it was low tech. And indeed, there were some practitioners who practiced mainly on basis of their experience rather than evidence-based medicine. And indeed, I had to airlift out a patient or two when they got too exotic or too complicated for our center. But by and large, patients got really good care. And I think that was because we established long-term relationships with our patients. I mean, I'm talking many years. There's been patients I've delivered 10 babies for, same lady. And you get to know the patients really well, and you can take better care of them that way. And most importantly, perhaps, people communicated, people cooperated. There wasn't any nurse-doctor wars. That was so out. I mean, nurses and doctors cooperated and communicated. And doctors helped other doctors. This was a revelation. I mean, it made all the difference in the world, and it hugely enhanced patient care. And then the internet came to the Flathead Valley. Well, this is very like the old Quadra I used to have, and in 1994, through dial-up, I was able to connect to the internet through our fledgling internet service provider, Cyberport. My, how we have come so far since then. And so we found that you could get all of the research findings and all of the clinical recommendations right up to the minute through the internet, minus the grumpy professor and all the meetings. And so this was fantastic. And of course, the governing bodies picked up on this, and they devised huge packets for us, huge amounts of articles for us to read, and then they would test it on us every year. And so was born continuing education based on the internet. So all the doctors here could stay up to date and not just rely on sort of the old ways. Moreover, the laws of technology hold true here, and as things got smaller and cheaper, we too got all the latest, greatest equipment. And so the gap between big city medicine and small town medicine got smaller and smaller and smaller. What has this meant for all of us here? Well, I'm here to tell you and show you that it has meant everything. I mean, everything, and in particular to this one patient whose case I would like to present for you now. I like to call her the girl who lived. Now, this was no ordinary patient. Really, none of them are. But I'd been taking care of her since 2002 and delivered all of her babies. And you know, you get to be pretty close with people. You care about them a lot over that span of time, and when you go through those kinds of experiences. And so she comes in with a beautiful pregnancy and labor, and in fact, the delivery was just gorgeous. And it was just moments after the delivery, and we were visiting, and this horrible thing happened. She collapses just profoundly and instantaneously onto the bed and turned a horrific shade of blue, dark, dark blue, like nothing else I had ever seen. And it was just, you know, striking, and you know, I immediately went into that space where I knew a major event had happened, and it's a moment of terror and a moment of calm, and everything I have ever learned or known came to the fore, and I could hear myself speaking code blue, and I could hear myself speaking amniotic fluid embolism, and I could see the room full of nurses doing all the things that I was saying, multiple IV lines being put in, oxygen being given, stimulation being given. And then a really extraordinary thing happened. She came to. And I thought, that doesn't fit. She shouldn't be coming to. But indeed she did, and it was like she picked up right where she left off. And she smiled at me, just like she had been, and she said, "Oh, excuse me, I must have fainted." And I knew in my own mind that that was no ordinary faint. And so I said, okay, and the code team has arrived and they see the smiling patient on the bed. And I'm like, well, no, an event happened and you need to stay. And so we're just gonna watch her. And we watched her and she looked good. She didn't have any unusual symptoms or bleeding. And so I let the code team disband. So I watch her a little bit more and everything's going well. We relax, she puts the baby to breast. When in the back of my hearing, I hear this decreasing tone of the oxygen saturation monitor. And I knew in this sickening moment that she was going to crash. And so I called the code blue again. Team comes in even faster this time, and I said, we just got to go to the operating room because I know that she's just going to evolve and she's going to deteriorate and we will have to manage her airway and she's going to have a massive hemorrhage, but meanwhile here she is smiling. So we go, you know, and I'm talking to the patient about all of this, and she understands, and we roll down the hallway, and indeed the hemorrhage begins. And it was just cup after cup after cup after cup. And she's small, and it was very, very alarming. But already the blood bank is mobilized and all the lines are in and we're prepared, we've got the team. What is an amniotic fluid embolism such that it could do this to a person? Well, it's mysterious and it's bizarre. But the essence of the situation is that a bolus of amniotic fluid from the delivery, moments before the delivery, is somehow thrust into the maternal circulation, say through a torn uterine vein, for example. And amniotic fluid is a lot like water, but it's not water. And it has detritus in it. It might have meconium or the baby poo, or it might have vernix, which is like waxy substance from the skin of the baby, but it doesn't belong in the maternal circulation. Suffice it to say, and this big volume comes up through the circulation and causes a kind of vapor lock in the vital organs, the heart and the lungs, and it stops them from functioning. So you've got a cardiac arrest and you've got a respiratory failure, and then, if that wasn't enough, you have kind of a total body like an allergic reaction to this foreign substance. And that takes its toll, lowers the blood pressure and so on. Moreover, you get an activation of the coagulation pathway so that it consumes all of the coagulation factors, leaving the patient unable to clot. This is very bad. It's set in the setting of having recently, moments ago, had a baby. So now she's really bleeding in the setting of all this other compromise. So she's intubated and she's being resuscitated from the head of the table with all manner of fluids and blood products and so on and so forth. And on our end of the table, we undertook to stop the bleeding surgically. And so we did an ultrasound-guided DNC, no help. We decided to pack her. We thought, because the basis of the bleeding is, in part at least, coagulopathy, so packing, no help. Bled right around the pack. So at that point, we made this dreadful decision to go to hysterectomy. And so you think hysterectomy, yeah, you do those every day. Not on a big, flaccid, over-vascularized uterus in a patient with no clotting. But do it, we had to, and so we made a big incision, thinking, okay, this will do it. But we get in there, and this uterus is completely distorted and injected full of blood. On this one side, it looked not like a uterus, but like a big maroon pillow, obscuring all of the surgical landmarks. And we didn't really know where to put a clamp. So we just proceeded anyway, working from the known side to the unknown side, and we were able to remove this uterus, and we were able to stop the bleeding. But of course, she couldn't clot, so there was some surfaces that we had to pack. We closed her, we took her to the unit. She stayed there, recovered, caught up in her blood products, caught up on her oxygen status. And the next day, we took her back to the operating room, took out her packs, closed her, and she started to recover. So there's a picture of the aftermath. How did she survive? Well, when you think about that question, think first about the fact that in all the other places in our country where amniotic fluid embolism occurs, and it is rare, 1 in 60,000, so it's difficult to study, those places all have high-tech and state-of-the-art equipment. Okay, tick, tick. Well, so that's not the difference. Hardly any of them survive. Of those that survive, most of them have vast neurological and other system deficits. So it was extremely unusual that she survived. So we have to ask ourselves, why was that? Well, so it probably wasn't the garden variety tech and evidence-based medicine. I want you to take a moment and look at this slide. You'll see a collection of different traits. And I truly believe that this is where the difference lay. Now, while you look, I will tell you a story. I have a surgical colleague, friend of mine, and he has this little expression he uses. And I used to think it was sort of sarcastic, but now I think that there's a lot of meaning there. And we use this expression anytime there was something kind of going wrong, something not going fast enough, and he would say, "Show me the love." And this is love. In a surgical, caregiving context, these things are love. And I want to tell you about the people who showed the love. Right starting from the patient. Now, she was incredible. Just when everything was hitting the fan, and everyone knew that everything was hitting the fan, she exhibited such a grace, calm, and confidence in us that we could only be calm and confident ourselves. And I want to tell you about this one moment, this golden moment with the husband. At one point, the room was full of people doing all kinds of invasive things to the patient, and he could understandably be extraordinarily distressed. But I looked over and I said, "Are you okay?" And he said, "I'm okay." And then he did this thing. He put his hand up in the air and he said, "You got this. I know you've got this. You do what you do." And with that, we headed off to the operating room, and it was so cool. Anyway, so I said I wasn't going to do this, but he said that, and it meant the world to us. It was like a benediction. So anyway, it wasn't only, there were so many people who showed the love. There were 3 OBGYNs in that room before we were done. There was vascular surgery, urology, 2 anesthesiologists, an intensivist, ultrasound, blood bank, nurses, all stayed far, far after their shifts. Everybody did double duty. Everybody in the room was working at red line. And to me, that's the only way she could have survived this kind of catastrophic, sort of epic, unheard of event that we really didn't even have a clear diagnosis for. And this is the result. So this woman, against all odds, had a full recovery. She had no neurologic deficits. She had no medical deficits. She was discharged on post-op day 11, which is this picture here. Not only did she recover fully, she recovered inspired. And she came to me in her post-op appointment and said, I want this case presented. I want it presented at TED, and I want you to put it back into the medical literature because there's not very many of us. And I said, we're gonna do it. And I think that's awesome. But what I think is perhaps even more important is for us to say, what was the difference? I mean, it was a set of shared community values and relationships that cause that kind of response to this emergency. There are emergencies in hospitals every day, everywhere, but they don't all get that kind of response. I know we had the tech, I know we had the evidence-based medicine, but how many places has this kind of practice culture where this many people would show up, in many cases unsolicited, and pour their heart out on a case all night long? And that's what happened with this lady, and that's I'm convinced, is the only way she survived. So on that basis, I'm telling you, we can do amazing things right here in River City. Thank you.